Okay, everybody? If we could take our seats, please. There'll be lots of time for chat over a drink and a canapé after the talk. So thank you very much. Let's try and keep this on schedule. Okay, brilliant. So for those of you who don't know me, I'm Nikki Cullum. I am the co-director of Healthier Futures platform. I'm going to introduce you to my new co-director in a moment. But I just wanted to welcome you all to what I know is going to be a fantastic evening. Now, just for those of you who don't know, what's a platform? What's she on about? What's Healthier Futures? Well, the research platforms of the university are the university's way of trying to bring about a lot more interdisciplinary research in challenge areas. And we have Creative Manchester, we have Sustainable Futures, we have Healthier Futures, and we have Digital Futures. And Healthier Futures is all about reducing health inequalities and trying to bring the firepower of the university's academics together with our essential external partners, whether they are local government or whether they are our VCFSE sector partners, some of whom I can see are here now, and it's brilliant to see you. Or whether, whichever bit of the system you are in, we can't all do this separately, but we can do so much more together. So it's brilliant to see you all here. So we're committed to doing more research and getting that, doing useful research and getting that research used in broad themes of how helping people live healthier lives, in healthier places, and with access to systems and services that help reduce the impact of those health inequalities. So as I say, we've got some of our really important partners in the room now, and I hope that some more will be joining us later. And so just to give you a snapshot of some of the things that we're doing at the moment, we're working very closely. Is anyone here from the Greater Manchester Combined Authority? Yay! Woo! So we're working with GMCA on, amongst other things, their housing work and how can we use academics in the university to help inform the housing planning of the Greater Manchester Combined Authority. So we've got collaborative work there. We're looking at regeneration and how it affects older communities in North Manchester, with particularly Manchester City Council. And we're doing a lot of things globally through our various institutes that work on global health. So there's a lot we're doing, but there's a lot more we can do. And we are very keen to have your suggestions about what that looks like. So on your seats, you'll see some postcards. And on the back of those postcards, which you are very happy to take, very welcome to take away, and we can give you more, on the back of those postcards, we encourage you to put ideas down, send feedback, share your thoughts, so that we can, do more good things with you all. So that's a brief introduction, and without further ado, I'm going to introduce my new co-director of the Healthier Futures platform, Sarah Marie Hall, who's a geographer, so it's interdisciplinarity in action, who's going to chair the rest of the evening. Thanks very much.
Hi folks, we are absolutely delighted to have Clare Bambra here. Clare is a Professor of Public Health at the University of Newcastle, but she also did her MA and her PhD here at Manchester, I found out just before, so this is like a homecoming for Clare. Clare also works very closely with several colleagues here at Manchester, particularly through the Health Equity North Partnership, of which you're a co-director, and it includes others like our own Luke Mumford, who sat over here. So Clare's research focuses on understanding and reducing health inequalities. She's obviously the perfect keynote for our annual lecture. She's also a Fellow of the Academy of Medical Sciences, a Fellow of the German National Academy of Sciences, Leopoldina, a Fellow of the Academy of Social Sciences, and an Honorary Fellow of the UK Faculty of Public Health. And on top of all that, she's also an NIHR Senior Investigator. So Clare leads a number of large collaborations, which includes a Wellcome Trust funded project that examines north and south health divides and inequalities. She's also been an independent expert witness on health inequalities for the UK and Scottish government and public inquiries into COVID-19. So this evening, we're really excited that Clare is going to be talking to us about her new book on the politics and policy of reducing health inequalities. The book, Get Better, look at that gorgeous front cover. The contents are even more gorgeous, I can tell you. On Getting Better, that's been authored with Julia Lynch and Catherine Smith, her colleagues. So we are going to have time for questions and discussion afterwards. So please do stay after to continue those conversations, and there's going to be a little drink after this is all finished. So I'm going to shut up now. I'm going to hand over to Clare. Thank you very much, Clare.
Thank you very much, Sarah, for that kind introduction, and thank you to you and Nikki and the team for inviting me to speak here and for hosting me today and for the next couple of days. It's very generous of you, and it is indeed an interesting homecoming for me. It's been a long time since I've spent this much time in Manchester and had a kind of proper trip back to the university. Of course, although I've been working with Luke for many years, it's been through after the pandemic, when obviously working practices changed, so I haven't had the chance to come over perhaps as often as I should have. So that's great, and thank you so much to all of you for giving up, the early part of your evening to come and support Healthier Futures and to listen to me speak. Hopefully, it will be worth your time, and there'll be some interesting ideas and data for you to think about. So, just as a little bit of a background before we go into the full kind of meat of what I want to talk about, is just to contextualise. Many of you are health inequalities researchers, health researchers. Many of you work in the parts of the system that deal either with health inequalities directly or with some of the determinants of that in terms of social inequality. This is, I'm afraid, one of many graphs that I might be using today, but all you need to really see is that the lines are going up. So over time, the life expectancy gap between the most and least deprived part of the country have increased, particularly since 2010. So health inequalities are increasing. A lot of my work since leaving Manchester 20 years ago has been about the causes of these increases, looking at social determinants, looking at austerity, looking at negative and unpleasant things. And myself and my colleagues, Julia Lynch from University of Pennsylvania and Catherine Smith from University of Strathclyde, decided that actually it was about time we tried to write something a bit more positive. Because what we really all want to know, I feel we know what makes things worse, and we're in a situation where things, as I've shown, are getting worse, but what can we do to make things better? And when you're talking to policymakers, at least policymakers that want to talk to me, ask me what they can do to improve things, not what they can do to make them worse. And I wanted to make sure that I had a good answer, a positive answer, and a narrative that we can use in difficult times to say that reducing health inequalities are possible. So that was our main motivation. Can we find evidence of it, and how would we go about doing it? And reducing health inequalities isn't just a kind of interest of a few researchers, as the Healthier Futures platform here across Manchester shows. It's an interest of a wide group of health professionals and academics. And it's been called by Richard Horton, the editor of The Lancet, that reducing health inequalities is like the holy grail of public health. It's almost like a mythical thing that we're all desperate to achieve, but we're not really sure if it's true or if it's possible. And so what we wanted to demonstrate with the book, that it is true and it is possible. And we do this by going about it in a different methodological approach than people normally do in public health research. So often in public health we might do a randomised controlled trial of a single intervention, or we might look at comparing one policy with another that might have happened over time through a natural policy experiment. Or we might do a systematic review of different types of interventions that are a bit similar that might have happened in different places. But these are all quite narrow. What we've done is we've started with when can we see in the scientific evidence base evidence of the health gap narrowing anywhere in the world, and what looked like it might have preceded that. And in many cases you often get a case of the gap closes because of something that happened before, then it widens again because of something that happens after that rather unique period. So there's this waxing and waning of health inequalities. And our thesis that I'm presenting today is that waxing and waning, the getting bigger, the getting smaller, is related to the role of politics and the policies that come about from different political configurations. So whilst I've made my career in public health, my degrees here from Manchester were actually originally in political science. So hopefully a little bit of that will come through, but I'm by no means a political scientist anymore. So what are the 4 case studies? And again, these are not the only ones, but they're the only ones I could find that had the empirical evidence that I could present to evidence the closing of the gap. There are potentially other options, but where we just don't have the data and measurement, given that we don't start, measuring health until, the 1840s. So the first example is the Great Society and the social reform program that happened in the United States in the 1960s. The second one is from Brazil from the mid-80s onwards, with the democratisation after the fall of the military dictatorship. The third one is the big change in life expectancy in East Germany that happens after reunification. And the fourth one is the one much closer to home, certainly for me. It's kind of the era where I cut my teeth in public health, which is about England's health inequality strategy that ran in the 2000s. So I'm going to talk a little bit about each of these, what happened in terms of the policies, what we can see in terms of the health inequalities trends, and then towards the end, I'll look across them and think, what do these cases across different places and times, what do they have in common, and what can we then potentially learn from that, and what happens when we don't have that kind of situation, the kind of waxing and waning issue. So, quite a lot to go through, so there's a bit of history. I'm not a historian, I'm not really a political scientist anymore, but the great joy of public health is that you can, talk about lots of different things, because lots of different things impact on health. And I think many of the things that matter most, as these case studies will show, are actually outside the health system. So, I gave this presentation a couple of months ago to an international audience, and when I had the Great Society up, someone whooped in the audience, and it was an American colleague who was overjoyed at having America shown as a positive example. And he said he'd never actually seen that in an academic conference. So maybe this is the America that should be being made again, the Great Society. So this was very much, you will be familiar with it, even if you're not familiar with that particular naming of it. But that's a broader kind of name that it's given, but it's the civil rights era in the United States. So before the social reforms that happened initially under JFK and then under Lyndon Johnson, America was extremely divided, obviously, in terms of racial inequalities, massive gaps in terms of poverty, particularly impacting on Americans of colour. So, for example, the poverty rates were around 20% overall, but this was double, it was 40% amongst people of colour in America. Infant mortality rates equally were double, particularly high in the southern states, particularly amongst African Americans. This segregation occurred across housing, in terms of people's access to healthcare services in the South, which was segregated by race, so people could be refused access to hospitals on the grounds of not being white. We get big educational inequalities in this period in terms of what proportion of black Americans finished high school, 40% compared to 70 to 80% of white Americans. So very, very stark poverty, lack of opportunity in what was at the time considered, in the kind of 50s, early 60s boom as a kind of land of opportunity. Equally differences in terms of class as well, cutting across that intersectionally. So the Great Society, there was very much targeted at this racial inequality and also the social inequality. It wasn't a gift, it was something that was agitated for, that movements under Martin Luther King and so on helped form. But what the basis of it, the kind of constituent aspects are listed here. The civil rights and voting reform obviously then enabled black Americans to have more of a voice, particularly in the South, which then agitates for sort of social changes and reforms that would obviously support them. There's a big investment in anti-poverty programs. This is pre-war on drugs from Nixon in the 70s. There was a war on poverty, particularly urban poverty. So you get the introduction and expansion of the aid for Americans with dependent children. So this was very much targeted at single women-headed households. It disproportionately benefited black American mothers, for example, pulling more of them out of poverty. Free school meals were introduced for those in receipt of welfare. The minimum wage, which had existed in America since FDR in the 1930s, was expanded in terms of coverage, and the value was increased. There's also educational investments, again, particularly targeting urban areas, and the introduction of the Head Start program to support early years interventions. There's a big program of social housing with over 500 million new homes built, many of which were targeted at deprived communities. And Medicaid was set up alongside community health centres as a form of health access to the healthcare system for people who were the very poorest. There was still a gap in the middle where private insurance was required, but this for the first time provided some coverage at the bottom end of the income strata. So huge changes. I've only provided a snapshot here. Julia Lynch, my American colleague, led the way on this chapter, and there's far more detail in the book. But what happened to health inequalities during this period? So we have these changes. Does it have an impact on health inequalities? Changing health isn't the aim of the programme, right? Those of us who are obsessed with health can't understand why you wouldn't want to change health. But obviously it's impacting a lot of the key social determinants, the key inequalities that ultimately drive health across the life course. This is a rather messy graph, I suppose, but again, you don't need to read it fully. I know Luke will be digesting it, asking me difficult questions over dinner later, but for everybody else, the key thing is that you can see at the top is the mortality rates for Americans of colour. The bottom dotted lines are for white Americans, and what we can see, and then it's divided by income. And the key thing to notice is particularly that fall on the middle line there of for higher income, black Americans living in the higher income counties falls really, really rapidly. And then you also get a closing of the gap between low and high income counties. It's an area level measure. And then you can also see a closing of the gap, particularly between 68 and 72 in terms of the inequalities by income, both for people of colour and for white Americans. This is a chart from Nancy Krieger of Harvard's work, and this one's looking at premature mortality, so mortality before the age of 65. You can also see similar patterns in her analysis of infant mortality rates. And for those of you particularly interested in this case study, she's also done work around maternal and reproductive health, as well as cancers amongst women, black women, and how that changed potentially as a result of additional access to better healthcare services during this period. So the biggest change is in the peak period. The reforms sort of kick in around the sort of 63, 65 period, and then you begin to get the changes in terms of the closing of the gap in infant mortality rates from around 1968 onwards, particularly through to 72. What you then find later, and I apologise, it's not entirely clear on here, but I wanted to show it by race as well, is an expansion again of the gap from around the 1980s onwards, and I'll return to that waxing and waning later. So the second case study is looking at democratisation in Brazil. Again, I can't claim credit for leading on this chapter. This was led by Catherine Smith in our book. But I can provide an overview here of what happened. So Brazil was a military dictatorship until 1985, when a social movement led to its overthrow, particularly under the leadership here of Lula da Silva, who was the president of the Steelworkers Union. So again, there's a social movement element to these changes. Brazil had been very much as a military dictatorship under coercive control. This is a period of deep censorship, poor workers' rights, poor occupational standards. There's no healthcare system to speak of for the majority of the population. Big economic problems and human rights abuses. There were housing shortages, and this is a period in which the favelas particularly increase and grow, and various other aspects in terms of, like the occupation of the Amazon and dispossession of land from native populations. Another important aspect of Brazil is at this time as well is obviously the legacy of colonialism and slavery there. It was a much more recent kind of legacy and quite hierarchical divisions, as the abolition of slavery didn't happen until the late 19th century, so almost 100 years later, for example, than in the United Kingdom. So you have a very deeply unequal country at the point at time at which you begin to have the emergence of democratic movement and of a democratic form of state. Democracy was an important part of the social changes post-1985, operating at multi-level democratic sort of across different parts within the community all the way through to the legislature, so not just a kind of hierarchical democracy that perhaps we're more used to in Western Europe. As part of the changes, there was also a huge investment in public and community health programs. Sometimes these were linked, as in the case of vaccination. This was linked to things you would get. Vaccinations would be linked, for example, to being allowed to attend school or being entitled to social welfare benefits. The anti-poverty programs, quite famous, the Bolsa Familia, a massive intervention again. In common with the American system of the 60s, it was targeted at women with children. This led to a big improvement in terms of pulling women, particularly women with children, out of poverty. Another poverty reduction measure was the implementation of a minimum wage, and over time, the different occupations, it expanded who was covered and the value of it increased, reflecting De Silva's own background in the trade union movement. There were improvements then also in terms of workers' rights and around occupational health and safety. The commercial determinants of health were also something that Brazil led on. They were one of the first countries to sign up to the WHO's tobacco framework, for example, Convention on Control of Tobacco, for example, and kind of really try to push this issue internationally. There was the implementation in Brazil for the first time of universal healthcare, and Brazil's healthcare system is still like the largest public healthcare system in the world, and the right to healthcare was enshrined in the Constitution in 1988. So again, we can see huge numbers of different changes across all the different social determinants of health. Housing we haven't got here, but that was also something where there were big changes in terms of trying to improve things, as well as schooling and early years education. In keeping with the American example, and perhaps more starkly even, we can see big improvements over this period in terms of reductions in inequalities. Here we have the differences by income in terms of the top and bottom quartile, so that's the top 25% of earners versus the bottom 25% of earners in Brazil over time. And we got it for infant mortality rates on the left and then for life expectancy at birth on the right. You can see here, if we take infant mortality rates, we can see the fall for both the highest groups and the lowest groups in terms of infant mortality rates over this post kind of beginning of the implementation of changes. And you can also see that the gap between the two gets smaller as well. And then this is reflected again in terms of life expectancy. Under 5 mortality also improves as well as the inequalities. And they will be driving the changes largely in the life expectancy. But they've improved things for everyone and also improved things faster at the bottom, hence there's a closing of the gap. There's also regional patterns to these changes. Brazil is a very unequal country, with the northern parts doing less well and being poorer than the rest of the country. And you can see that the regional inequalities in health here also declined during this post-policy period. We don't have pre-data for Brazil. The military dictatorship didn't tend to collect health statistics and publish them, but we do have these trends over time. And this comes from the work of Brazilian public health researchers, various ones that we were able to access in terms of not being in Portuguese. There may well be more data, but unfortunately beyond my skills. So here is our second example from a very different context, but some similarities in terms of this big social movements leading to big social changes associated with changes in health inequalities. Now I feel slightly more comfortable because we're getting on to the third and fourth examples, which are the ones that I led on in the book. So this is looking at, third case is looking at reunification in Germany and what changed in terms of health there. So again, this is another radical change, right? I gave this talk to my Masters in Public Health students on Tuesday, and I realised that for some of them I did need to explain quite fully what communism was, what East Germany was, because it wasn't like a seminal moment in their lives. And I can see that I'm probably looking at 20 to 30% in the audience here that might be similar, and the rest of us are like, yeah, we remember that, Claire. So I'll do a kind of mid-version, which is, of course, Germany was divided after World War II. The eastern part, quite a small part, is an artificial division, and the eastern part had been occupied by the Soviet Union after the war, the western part of Germany by the Allies. Basically, Russia didn't leave after, occupied it, and turned it into part of the Soviet bloc as a communist country. Albright comes in as a kind of proxy leader, in a sense, on behalf of the Soviet Union, and communism is implemented in a kind of Soviet-style model onto East Germany after the war. Now, there are issues from that which are relevant, I think, when we talk about the health. One of which, obviously, it's a communist system, so lack of freedom of expression, no actual democracy, and a kind of the GDP of the country is quite low, particularly from the 1970s onwards, relative to West Germany. East Germany also had to pay huge reparations to Russia for its role in causing the Second World War, in a way that West Germany didn't to the Allies. So this leads, for example, between 1945 and 1950, about 60% of East Germany's infrastructure, so factories, railway lines, etc., are pulled up and literally carted off by train to Russia. And they also have to continue paying financially to Russia over the rest of the lifetime of the country through till 1989. This obviously has big impacts for them as well, and they're very dependent on Russia for gas and various other imports because they're part of the Soviet bloc, and so they're subject to trade embargoes from the West. So this is a world that I grew up in, as many of the people here did, and for the rest of you it feels like ancient history. But it's an important context to be able to then understand what happens. So this again, as with the Brazilian example, reunification, East joining back with West, becoming the West German system being, some might say, imposed upon East Germany, has, I would argue here, some benefits. I know that some East Germans would feel some disbenefits. Not everything about the East German system was problematic. For example, their polyclinics are now something that many governments are talking about implementing. So, right, that's 101 on communism. Now we go back to the case study. Right. So, because of the reunification, East Germany goes from being this totalitarian system with poor living conditions into what was West Germany, with the mark at the time was, and still is, the strongest economy in Europe and any kind of second or third in the world. So there's a real big change potentially in terms of quality of life for people. This doesn't happen overnight. It's a transition period. There's a lot of deindustrialization in East Germany as the state collapses and all the nationalized industries are privatized and sold off. Huge increase in unemployment, for example, in the East. And when you look at quality of life studies, you can see that actually a couple of years after unification, like after the euphoria has kind of gone, then there's actually quite a big dip in quality of life as people report it in surveys in East Germany, before it gradually picks up again over time. The reunification is an economic and a political unification. So you do get democracy within East Germany for the first time, since 1933. So that's a big change. There's also big financial transfers between West and East. And it's been estimated by economists that the reunification has cost Germany around 2 trillion euros over a 20-year period. So there's big financial transfers in terms of, for example, around pensions. Because there was a commitment under Helmut Kohl after reunification that an East German mark, which was basically a worthless currency, would be switched 1-for-1 with a West German mark, which was a very valuable, it's like swapping it for a euro, right? This meant that pensions in the East became very high, particularly for women, because women in the East under the Soviet system had working lives that were almost equivalent to men and certainly much higher than West German women. West German women much more likely to be homemakers under the kind of Christian democratic system that Germany had been, particularly in the 70s and the 80s. So that improves people's income, particularly in older groups. You also get an extension of environmental regulations, a clean-up of highly polluted rivers, a massive reduction in air pollution. So East Germany didn't have its own source of energy. So it either imported from Russia or it burnt this lignite, brown coal, which if there are any engineers here, they'll know that is the most kind of polluting form of fossil fuel possible. And so there were big problems from that regard. Occupational health and safety, you might think surprisingly, given that it was a workers' state, was extremely poor. Alcohol use was widespread during the working day. And there's some interesting data in the book chapter about this that we got from some historians around, exactly what it was like at a kind of towards the end of East Germany's life in terms of the alcohol use at work. Housing improvements were also implemented. There was a lot of overcrowding in East Germany. You were allocated a house. It was not necessarily big enough. There was a very poor, lack of repair on properties over time, and they had declined considerably. Around 60% of the funds that went from west to east was spent on social welfare benefits, including pensions. The rest was spent on roads, rail, and healthcare. The healthcare modernisation that happened in East Germany post-1989 was very rapid and immense in a sense. Whilst there were some positive kind of structural approaches like the polyclinics around primary care and access to services in the community that had happened in East Germany, the hospital system was like a 1950s system in contrast to, the technology of the late 80s that West Germany had. So there's a big improvement there. As an example, East Germany owned hospitals and physicians only had access to around 10% of the different types of drugs that a West German physician or a UK physician would have had at the time. So you can see it would be much worse for you if you fell ill in East Germany with the same disease as if you fell ill just over the road, just over the wall in West Germany. So that's a massive factor. And then because of the trade embargo that impacted all of the Eastern Bloc, people's diets in East Germany were very old-fashioned, very traditional and very seasonal. So this is kind of high-fat, pork knuckles with dumplings and so on, a real lack of fresh fruit and vegetables, particularly out of season, because you're not able to import. And those of us who can remember that era will be aware of the kind of images of people queuing for hours to get basic products, queuing for hours, when bananas finally, came across from Cuba. So, what does this all mean for health? Sorry, I could talk about East Germany quite a lot. It's one of my pet projects, but I have to remember to get back to the main point, which is that it's about how health changed, how health improved in this reunification period. Another graph, there's only one graph per case, it's not too bad, right? This one I think is easier to understand. So you can see hopefully along the bottom, it runs from 1956 through till 2020. That's just the data that was available. So we can't get before 56 for East Germany. And we run through till 2020 because that was the most recent when we were publishing the book. This is life expectancy for men and women. Women are on the top, it's higher, men are on the bottom. The solid lines in both cases are for the West, and the dotted line, the lower one, is for the East. So what you can broadly see is that for both men and women, East Germany keeps up with life expectancy until about the mid-70s. This is when the East German economy is no longer able to keep up, in effect, with the living standards of West Germany. And at this point, you then begin to see the falling away in terms of life expectancy for both men and women in the East. At the point of reunification, which is around 1990, then the gap stands at about a 4-year divide for both men and women. And as you can see then, post-1990, you get this actually really rapid closing. It's within a sort of, 15 to 20-year time period. That gap has gone for women, and it stands at around 9 months for men. So this is a really big change. As we're in a UK audience, we just need to reflect on that, what's happened in the same time period to our own, let's be honest, arguably less significant north-south divide. It's got slightly bigger. It's gone from around 2 years on average to around 3 years on average in the same period. As another aside, life expectancy of East German women is now significantly higher than life expectancy for women in the northeast of England. So there's been this is a former communist country. Kind of makes you wonder what we're doing, or rather not doing. So this is a really, really rapid change. And I'm giving a presentation next month about it in Germany, and I've got the impression that I might be challenged a bit on my kind of West German triumphalism, which I don't mean, and I think they think it's quite a puzzle over there and it's quite controversial, because it's not all explained by everything I've said. I can make the story right, but you can also think, what about the deindustrialization? What about the aging population in East Germany? I think there's a story. I've got my thesis, but there is a little bit of wiggle room, I think, around why this has actually happened and how much we can learn from it. Okay. Turns out I can talk for quite a long time. I didn't realise. Apologies. Now, hands up in the room, anyone who can remember this one. 1997, things can only get better. Who had their first vote then? Yeah, it feels better now than it did then, actually, right? Because now we know what comes afterwards, yeah? Nikki's looking shocked, but come on. Get your rose-tinted glasses on. Nonetheless, from a health inequalities perspective, as measured in my next graph, things did get better. Nikki's looking really sceptically at me, but they did. So this wasn't really ever an actual, here we go, we're going to articulate it as a strategy. It kind of was retrospectively. So Labour gets in 97. Again, this is for some of the people who didn't put their hands up, right? Who were too young to remember this era. Labour got in after 18 years of Tories under Thatcher. There'd been absolutely no interest in health inequalities during that whole period. There was no research funded on that. The best people got was the Health Variations Programme under what was the Economic Research Council under John Major in the mid to late 90s. Once Labour gets in, they set about a new commission called the Atchison Inquiry. This looks into health inequalities, highlights various areas, makes lots of recommendations, some of which are around different, what we would now consider theories around health inequalities. There's interventions around how you can improve health behaviours, with, smoking cessation services in poorer areas, investing in healthcare. There's stuff around housing and neighbourhood health. There's stuff around early years, occupational health, minimum wage, etc. And certainly in that initial period, the sort of the first year, government, 97 to 2002, there's a lot of this is actually implemented. And it wasn't badged as this is for health inequalities, but it was happening because there was a wider agenda. So, for example, you get a big investment in poorer areas, directly and indirectly. Directly through things like health action zones and neighbourhood renewal funds. Indirectly because there's big increases in social welfare going to, again, poorer families, and particularly benefiting women in headed poorer families. So this is, for example, with the child tax credit, the working tax credit. 1 million children are taken out of poverty in this period, and we also see investments at in later life in terms of Pensioner poverty declines in this period because there's a minimum pension guarantee brought in that raises the bottom level. This, again, particularly benefited women who didn't necessarily have enough of the national insurance credits from their official working lives, so it increases their pension rate as well. And we did some work that showed that mortality in older age groups, the inequalities decreased in this period. It's also, again, in keeping with our other examples, a big investment in the NHS. So this is investment and funding for the NHS goes actually up in real terms, so above inflation, above demographic change. The amount of money spent per year on the NHS is actually increased, as opposed to being a below inflation investment, which is what we have at the moment. The minimum wage is introduced, so this is the first time. If we flip back to 40 minutes ago, and I was talking about America, they had a minimum wage since the 1930s, so it's quite interesting that we don't get it until the late 90s. There's some studies by people like Aaron Reeves and colleagues that found that when the minimum wage is introduced, you get an improvement in mental health across the workforce and a closing of inequalities by occupational class in terms of mental health, for example. Sure Start centres, many of you will be familiar, particularly those here from the voluntary sector who are here today. These were investments in centres to help children and families in the early years, targeted at deprived areas. They've been extensively evaluated and found to improve all kinds of outcomes, including things such as inequalities in obesity. And of course, we had leadership in terms of tobacco control with the introduction of the smoke-free legislation, and there's studies from Scotland and from England showing that this decreased inequalities in admissions to hospitals for heart attacks, for example. So, again, a lot happens. It's not as radical as the other examples. There's no huge social movement backing up Tony Blair and Gordon Brown in terms of what they were doing. But nonetheless, what they did arguably looks quite radical now, even though I was certainly one of the people who was disappointed as a youngster that they weren't radical enough, right? But now, let's say compared to the current government, at least in my opinion, I was hoping for more. I was hoping for more when I wrote the book. There is a prescription, there's a policy here from their own predecessors. So maybe Peter Mandelson could have, brought some of this history over rather than his own rather dodgy one. Right. Apologies for that one. So this is why it matters, is because it is actually about, improving the health of the poorest and decreasing inequalities. This is infant mortality rates. And you can see yet another graph. There's a policy period, is the shaded area, and the gap here is between the bottom 20% of local authorities and the national average. The reason I've got that is because we did the analysis of this, and that's because that was the target that the government gave itself. Right? And there was controversy, at least within health inequality circles. Just after the change of government around 2012, Johan Mackenbach, who is retired now, but he was a quite senior Dutch epidemiologist at the time, wrote an article in Social Science and Medicine saying that the English health inequality strategy, the most holistic and advanced of its time, had failed because it had failed to reduce health inequalities. And I was lucky enough to see a debate a few years later, which between himself, various others, and Michael Marmot. It wasn't a public debate, it just happened on a random teleconference that I was on, because actually if you waited a little bit longer to see the mortality changes, and you had data that went beyond 2008, then you can see the changes kicking in. So these changes, I always think health inequality is like a tanker, that we can't change it quickly. And he jumped the gun. But the reason it mattered is because I was invited to speak to the Shadow Health team under your own Andy Burnham at the time about health inequalities, and I can remember Diane Abbott asking me and saying, what can we do about it when the whole strategy failed last time? Because this had got somehow through to the Shadow Health team. She was Shadow Public Health at that point. And I was able to show new data that I'd done as a letter that showed that it was beginning to change. Then a few years later, Ben Barr, one of mine and Luke's good colleagues at Liverpool, started showing that actually once you get the mortality data from more recent years, you begin to see the closing of the gap. And you can see it now in proper analysis. These are done, proper economic analysis. Luke can tell you about the details on that. You can see it for infant mortality rates, what is present here. We did it for mortality over age 65. Ben led a paper in the BMJ which showed it for mortality amenable to healthcare, which was showing, the particular role that healthcare investment had. And so you can see it across various different indicators. So it was successful, and that's why it does matter that we're able to have these examples, I think, and these narratives. Because if you do have policymakers that are interested, and that seems quite a spoilt position to have been in perhaps, then you want to be able to empower them and also give them the tools and the thoughts to think, actually, we can do it. So, what actually reduces health inequalities? We've had my 4 case studies. I've talked a little bit about what I think's happened, what we think's happened in those different case studies. And I think there's quite a lot. This is obviously a very simple analysis. I'm not going to pretend it's anything more than that. But sometimes I think there's a role for theory and thoughts and kind of knowledge based on what the COVID inquiry calls expert opinion. Hopefully evidence-based expert opinion. So I think in all of the cases, there's very much evidence of expansion of healthcare. There's expansion of social welfare that benefits in terms of decreasing poverty and bringing people up from that perspective. There's some evidence around improved housing, but it's not as strong. It's not as strong a policy in all of them, and the health impacts of that are less clearly understood. All of them have an aspect of reduced inequalities, with the income inequalities, with the exception of England, where it depends how you measure it. There's increased political enfranchisement. That's evident very strongly in 3 of the 4. And then we can see that there's work around the commercial determinants of health. Again, not in all, but a bit in some of them. Improvements in terms of environmental health matter, particularly in the German case. And then we have a little bit on kind of occupational health and safety as well. So these are the different things. I think you could also add other things in. You could also add in action around the early years. These programs that happened are not one or other things. So what I'm trying to show here is not necessarily which of these can we take and implement. It's more that actually they're all different pieces of quite a complicated puzzle or mix of policies that all happen, kind of everything all at once. I think, though, and I argue with my colleagues, we argue, that there are 4 kind of great levelers in our work. These are not them, just to be clear. This is where we got the idea for the great levelers. This is from a book, so I like to acknowledge where I get my thoughts from Walter Schneider, who did a book, you might have read it, about the history of inequality, and he looked at when has social inequality decreased over human history. He has 4 examples. He writes a really fat book like that. You'll be pleased to know mine's actually really thin. I can't pretend I read every word, but I read enough to get the idea that actually this is an interesting way of going about things. So he looks and he sees when have we got evidence of it and what was happening that might have driven that. So he has mass mobilization warfare, so inequality reduces after the First and Second World War, both by income and by gender. Transformative revolutions, if we look at things, like in fact, our own case of Brazil. State collapse can have an impact, and pandemics, famously the Black Death, reduces income inequality because so many of the peasants are killed that the power of labour increases, at least for a short period. So, all totally irrelevant in terms of the topic, but the idea of looking like that is what inspired us to then think across our cases, what are our 4 great levelers? What are our 4 big picks in terms of when health inequalities have decreased? We can't look over 1,000 years, although Simon Schweitzer at Cambridge has produced some interesting work about what happened with the changes, the introduction of the Elizabethan Poor Law and how that reduced mortality amongst the poor. And then when it changes again with the new Poor Law in Victorian times of the workhouse, you get an increase in mortality again. So you can do some historical analysis, but we can't do it over 1,000 years. We've done what we can. We go back to the early 60s. And I think from our 4 cases, we can find these 4, what I think are the kind of big levelers for health inequalities. Probably no surprise if you've been able to listen to all that I've said. expansion of the welfare state, and obviously the impacts that has, on poverty, reduction of income inequalities, improved access to high-quality healthcare, and sort of driving, to some extent, all of this, I think, is the bit that's harder to measure, which is this enhanced democratic participation and the political inclusion, which arguably then drives and leads to this. So there's evidence, for example, when women get universal suffrage in countries, that you then see a change and suddenly social welfare, for example, becomes more important. So having a voice, having a vote can shape, of course, what then policies happen, because they're going to have to take into account, in this case, women's interests, for example. So I think we can't necessarily measure it from a quantitative perspective, but it's hard not to think that, shifting from a totalitarian communist regime to a liberal democracy must be having some kind of impact, at least in terms of driving the other levers. So that's quite a lot to take in, I'm sure. And then one of the questions that we get asked is that this is all well and good, you've got these really exciting, if radical and unusual, unicorn-like case studies, Clare, but what happens when the politics changes and the policies change? These are all perhaps what might be considered quite special events. And we do talk about that in the book. We analyse, what produces the waxing and the waning. And you can see, and I mentioned it in relation to what happens to inequalities in health inequalities in America. You get that improvement post-60s through into the early 70s. Then you get Reaganism and neoliberalism from the 80s onwards. Poverty increases, income inequality increases, and health inequality increases. That is literally the topic of another book called Neoliberalism and Health, which I'll be happy to give another year, Nikki. But we can also see it in all of our examples, bar Germany. So, when Brazil becomes more monetarist, neoliberal, starts implementing austerity, we get reductions again in our, in the health benefits to population. And we can see it in the English example as well. So here is looking at, it shows very strongly on the left-hand side this relationship between child poverty and infant mortality. And you can see it's obviously quite exaggerated in a sense because of the scale that we have on the y-axis to sort of show this dramatic effect, which is the association between the two. As child poverty rates go down in England, infant mortality rates go down. As child poverty goes up, infant mortality rates go up. And in this graph, it's showing, again, that decrease in inequalities in infant mortality that I presented with the policy period. And then we can see child poverty goes up, infant mortality inequalities go up. And this is, of course, the inequality strategy period with all the expansion of things, followed immediately by austerity and the cut. Child tax credits go, Sure Start goes, almost everything that Labour government did gone very, very quickly. So that's a kind of lesson in terms of, how you might need to enshrine things in constitutions, etc., in order to bed in some of your political and policy changes. But there's definitely this waxing and waning, or what you might call a dose-response kind of relationship with political change. I think we can also see this if we go over a bigger time period. Again, probably don't have time for me to do this lecture, but here's one where Thomas Piketty does his income inequality over time in his famous book Capital. This is for the UK, so you can see how income inequality measured as the share of income of the top 1% decreases again through to this kind of mid-1970s, then goes up again. I studied various historical research, studies that people had done on historical health inequalities and pieced that together to try and see if there was a similar patterning. So this is all a little bit partial, but I think you can see over the long 20th century 4 kind of political periods, and that you can see a change in health inequalities broadly reflecting a kind of U-shaped curve in that period. We'll talk a bit about that in the introduction to the book, and I also have a paper on it. But my argument for you today is that I think we can see this waxing and waning, not just, over a 10-year period in England or a 10-year period in Brazil, but over a 50-year period in America, and potentially over, the last whole century. So I'll conclude now because I've definitely had my time. Back to the beginning. It is possible to reduce health inequalities. We've demonstrated it. There are 4 case studies here. They're all really different, and I'm sure we can each pick something from it that we can take away and use in those conversations that we have. There isn't a single thing. I can't say what exactly of each of these. We've tried to pick out the broad, principles, but there's a lot going on in different places. There's many moving parts in these changes. It does wax and wane. Health inequalities are deeply political. They're driven ultimately by the choices of policies that governments do or don't implement. And I think methodologically, this is something that we have, this case study approach is something which I think complements traditional public health approaches. And we've got an article coming out in Journal of Epidemiology and Community Health that sort of tries to champion that side of the book in terms of otherwise, if your only tool is a hammer, if your only tool is a randomized controlled trial, then nothing reduces health inequalities, right? So we do need to think differently in what standard we hold ourselves to, and therefore what stories. Thinking back to that debate I had with Diane Abbott, what stories we tell, I think, still matter. So thank you for your attention.
Thank you so much for that, Claire. This is working? Yeah? Wonderful talk there. I made loads of notes. Got a cheeky question to ask later. Are you sure you're not a political economist? But we have about 15 minutes for some questions to ask of Claire. I think, would you feel okay about taking maybe 2 at a time so that people get a chance to ask their questions, or would you prefer 1 at a time? Okay. Okay, there we go. It's a deal. Any questions for Claire? Please feel free to ask. Okay, so we've got a lovely blue shirt and orange armband here. Please ask your questions into the mic and do tell us who you are.
Hi there. I'm James Banks, an economist from here at Manchester. Terrific talk. Thanks very much, and a really good choice of case studies and episodes. I wanted to pick up on this thing about the timing and the supertanker. Some of your mechanisms you think can have pretty quick effects, and a lot of them are potentially pretty slow. And whether or not you've managed to use either things on inequalities in conditions or causes of death or ages of death to really sort of separate out those and be a bit more precise about the timing of the effects of these policies. I mean, the challenge, I think, of the East German example is that if you can equalize life expectancy within a 10-year period, predominantly driven by the mortality rates of the elderly, actually, does that mean, really, that all of that early life stuff and life course health doesn't matter? So I think there's a real challenge here to really say what is the speed of the tanker is kind of different in each of these dimensions, and is it possible to use diseases or ages of death or something to drill into a bit deeper into that?
Yeah, I think that's really interesting. If you didn't fully hear, then the question was about whether digging into different ages of death might be a good way of seeing, again, which mechanisms might be more effective or which groups you could potentially, I guess, target through different policies. And yeah, the East Germany is largely older people who benefit both from the pensions that I mentioned, but also obviously they're using healthcare more. It should also be noted that in East Germany, pensioners were very poorly treated, even relative to workers. They had less money because they were seen as non-productive. They were even allowed to go over to the West, right, freely, because basically the state didn't care if they didn't come back. So they're in I guess what I'm saying is that they're in a difficult situation, and then they're moved quite rapidly up with the income changes. What the East German case means in terms of what we know about early life year stuff, I don't know if it necessarily challenges it without us looking more into early years in East Germany, where I think the polyclinics, infant mortality rates in East Germany are not particularly higher, at least, you know, in a historical sense, I think, than other countries. You know, it's not a huge outlier. But yeah, I think that's an interesting point. We tried to do it where we have more data. It's easier with the Labour, you know, the English example, where you can see the changes at different stages of the life course. Thank you.
Wonderful. Let's get those hands up again, please. Any questions? So we have patterned, lovely patterned top. Oh, hello. Hello, Holly.
Hang on a sec, can you...
There we go. Now I'm on. Yeah. Lovely. Smashing. Claire, you've really beautifully set out the link between public policy and improving health. How do we collectively convince politicians to look beyond short-termism and to look beyond their own premierships to really, really invest in this?
Yes. Well, I have interactions with policymakers, as I gave in my example, but rather than getting more over time, I think they probably got less. Not through lack of trying. I'd say that with the support of Health Equity North, I tried quite hard and probably more present than I used to be. But I think there's less interest, at least from front bench at the moment, of the government on this, although they do still, and I was reassured by Department of Health colleagues a couple of weeks ago, that they still have a commitment to halving the regional gap in healthy life expectancy within, I think it's 5 years or something. That's a massive ambition, literally doing nothing to actually meet that. So I think there's a change in narrative is needed in terms of what you need to do to reduce inequalities. There's still a slight hook, but I'm not getting the sense that it's certainly not, you know, 2000, post-Atchison, etc. I think partly it's who's literally in charge within the current governing party, which part of it's in charge. I think it's because of the kind of poly-crisis that's happening, so the eye is arguably, understandably, you know, on other balls. And then I think it's a kind of almost kind of falling for the fact that it can, you know, inequality is changed through growth, improving growth, or through, you know, I don't know, access to digital services. That's not to say these things have no effect, but they don't magically have an effect. So I guess there's an ideological challenge amongst some politicians. Yeah, I'm afraid I don't have the solution to that one.
Thank you. Another great question. We had a question here. I saw another lovely shirt, white and blue. Please, thank you.
Thank you. So hello, my name's Thomas House. I'm head of probability and statistics in the maths department here. And so I'm unsurprisingly going to ask a question about metrics, which is that in the trente-glorieuses, kind of split into deciles and track the top and bottom decile is a pretty sensible thing to do. And then I saw people online going, oh, but we've never taxed the wealthy more. And I thought, well, how can that be right? Because that's not what we're really seeing. And it seems that the deciles make sense when the top decile is really where the wealth is. But actually, if the wealth is in like the top percentile or 0.1 of a percentile, so you have Elon Musk with like a state-sized wealth, that isn't reflected in income deciles, right? And that seems to intersect with this slightly odd thing where I just read Ded Cohn's book, and she's talking about these tech billionaires spending money on things with a very poor evidence base that are not going to lead to them living to 120. They're probably killing themselves young by doing all these ill-advised things because no one will tell them no. So I wonder if that we need better metrics like, you know, how much of those dollars are wasted where people in the bottom half, right, are not getting things that are really evidence-based, or doing anything like that counterfactual, because like I said, there's nothing wrong with the chop into deciles, but it seems to be straining under the very odd economics that we found ourselves in.
Yeah. So some interesting thoughts there. Were you getting at, in effect, because I just had the one metric up from Piketty there about income from the top 1%. Obviously, he has lots of other ones. I just had one graph to show that. And there are different metrics that are used to measure, and they will broadly, I think, show this same U-shaped curve. Possibly not for things like wealth tax, property taxes, but only because that's kind of done less, I think. But I'm not an income inequality expert, though, I'm afraid.
We also have a question at the back, please. Thank you. And thanks to Laura and Louise for running around with the mics. Thanks.
Thank you. That was a lovely presentation. And my name is Çağlar. I'm a lecturer in urban planning. When I started working with colleagues from public health, I actually didn't realize, I appreciated how woke public health is, like how much social justice is actually at the center of it. I didn't appreciate it at the very start when I was working with colleagues. And I'm actually surprised that it's not as political as I think it should be, perhaps. What I mean by that, or maybe get your thoughts on, do you think that public health as a discipline should be more political? Faculty of Public Health perhaps should be endorsing, saying, vote today for pro-environment, pro-social justice candidates. Public health lecturers should tell their students today, vote for candidates that perhaps will make your life better? Or do you think that might be a slippery slope?
Cool. I like that question. So about whether public health needs to be more political. I mean, obviously, I think the answer is yes. And when there's been big public health changes, you're looking, for example, into the 19th century, then there were big public health movements. It was political to get a sanitation boards in. It was, political. Many of the changes that benefited public health, even the Public Health Act, are political changes. And obviously, I've outlined what is, I think, needed to reduce health inequalities. The reason why public health, professionals and researchers don't tend to be political is, for the professionals, it tends to be, particularly since their change of employment from the NHS to local authorities, is that they're quite constrained by being in a local authority, which as an urban planner you would probably also understand, so literally PERDA and things like that. So that, I think, makes it difficult for them. It's important that whatever they would say would be evidence-based. Evidence is, of course, disputable. I'm an academic, I can interpret this, and I can give an interpretation. I think that's harder to do as a practitioner. And then for researchers, often it's probably because they're not, trained in the same way as I was through political science, but also because this is not the sort of stuff that tends to get you many grants. I've got a whole other far less interesting portfolio that gets me grants and nobody ever asked me to talk about, but there you go.
Thank you. We've got time for some more questions. So we have a question here at the front, and then I've spied another lovely shirt for the next one. So at the front, blue jumper, please. Thank you.
Hi, I'm Callum Wood from the Policy at Manchester team. Just a quick question. You talked about polyclinics as being one of the sort of the good examples from East Germany. Would you mind expanding a bit more on what polyclinics are? And then also you said that current governments are looking at those as a model of healthcare. If you wouldn't mind just talking more about that.
Thanks, yeah, I will. So these are polyclinics in East Germany. When they built their new housing developments, they wanted everything to be in place. And so you'd have a neighbourhood school, library, etc. Everything would be in place, including a polyclinic. So within that, you would have access to primary care, but also to dental services and even some specialists, specialists, doctors, depending. So that model existed. I think that's the sort of thing when we're talking about neighbourhood health centres, getting services out into the community, sounds a lot to me like a polyclinic model. They're never going to call it a polyclinic. In what was West Germany, there is also moves to a similar approach of kind of trying to deliver more. Germany's very hospital heavy even now compared to us. That benefited them in pandemic, but in normal times it's not really a great place to be from health service resources. So they're trying to do it. I doubt, again, very much doubt they call it polyclinics, but I have seen like articles saying this is a re-emergence of the polyclinic, if you see what I mean. I think there was a letter in the BMJ about it or somewhere like that. So it was it was certainly an innovative approach in that early period.
Thank you very much. Please, can we double check the mic's working?
There we go, they're back.
Sorry, hold off please. We've got a question here at the front that I already spied. Can you just wave your hands, those who did have questions just then though, so I've got you, Tess. Yeah, thank you. Yeah, thank you.
Hi, I'm Lucy. I'm a consultant in public health at Manchester City Council. So what you said about us being quite politically restricted is true, especially we're in Purda at the moment. Yeah, there are limitations on us in our roles because we're in a political environment. But what I wanted to ask you is, we're doing a lot in Manchester about social determinants. We've got a whole programme based on Marmot called Making Manchester Fairer. But a lot of what you've said today is it's more that national political level and policy making level. I suppose, have you got any advice for the local level, or is it more around looking at what you've said and trying to implement that at a smaller level? For example, our anti-poverty strategy at a Manchester level, rather than trying to focus at that national level. Have you got any advice about that, I suppose? Thank you.
Yeah, I mean, obviously I don't have to work in your kind of sensitive, politically constrained environment, so I can give a flippant answer and then a better answer. The flippant answer is get Andy in, right, nationally. I think Andy Burnham would make a difference because I see him more in the kind of mould of a Gordon Brown, and really the health inequality strategy is led by Gordon Brown's interventions in terms of child and old age poverty. That would be my kind of political thought, which addresses, I think, again, the question earlier about political ideology and the changes needed. In terms of what can you do locally, obviously when I present my stuff, I try and say it as an optimistic thing, but then obviously you can also think, well, I can't do any of that, right? I don't have any of those levers. I think, and this reflects the question earlier about the politics of public health people being political. I think we can speak more to the evidence, right? You know, I think there's maybe too much hesitancy around that, not so much for you as an individual practitioner, but for our professional organisations. If we look at the Faculty of Public Health, we could be speaking out a lot more. We do it on things which are like, I don't know, 20-mile-per-hour roads, or, you know, whether we should be taxing fast food, things that I think are seen as more clearly public health, right? But we could also be doing it on these bigger things too. You know, reducing poverty does matter. So there's a way we can do that through our associations, our societies that have a bit of an expert voice. And then locally, yes, pressing on with what you can do, where you can do it, and also engaging more with this agenda around the healthcare inequalities agenda, because that is the bit that does seem to have more prominence under the current government. Thank you.
Thank you. We'll go to Tess in the chic beige cardigan.
Thank you. Hi, I'm a researcher with Manchester Urban Ageing Research Group. Following on from the conversation about the political salience of public health, I was just thinking back to COVID and how public health was really platformed quite a lot during that time, including, you know, in terms of health behaviours and interventions of the determinants of health, like housing and bringing like homeless people into housing, for example. And I guess, kind of following from that, I thought, or I don't know if others did, but maybe that public health would continue to have more of that platform since that kind of big event. And I'm wondering if kind of you've seen any changes since then in terms of it generally being more in conversation, or whether that's kind of been like compartmentalized and sort of we've moved on from that now, which is how it kind of seems from you know, the general perspective, yeah.
Yeah, I agree. Public health kind of had its moment, didn't it, during COVID, for good or for ill. So we got a lot of attention, and a lot of these issues came up, including the stark inequalities in COVID mortality and the intersectional nature of that. And then over the last few years, it's almost like, so after the Spanish flu in 1918, you almost hear nothing about it. There's almost no kind of novels or anything about it in that period. It's called the kind of great forgetting, like people just, it's almost like they just want to forget it. And I think there's a little bit of that for all of us with COVID, right? Even though it was nowhere near as traumatic as Spanish flu was by the kind of observational accounts, right, and from the mortality data. But I think there is that great forgetting amongst the general population. There's also, obviously, it introduced huge focus on public health. We used to kind of go under the radar with the public, or we used to be seen as, oh, someone telling me not to drink and smoke. Now it's suddenly they're telling me not to go out of the house, right? There was, I think, a negative attention as well for us in that period, which I think we still have some of that, you know, with the kind of lack of trust in vaccinations and so on now. I think there's a legacy there that we have because of you know, our prominence during the pandemic. And things move on very quickly, especially I think now, you know, every week it's almost like a new kind of global crisis, right? So pandemic is so like yesterday. As a little anecdote, when I gave evidence to the COVID inquiry with Michael Marmot, when we gave it the first time in 2023, because the Conservatives were still in government, there was loads of media attention for what we were saying. Then we gave evidence, I think, earlier this year in February, no interest at all, nothing, right? Which shows you, and that's not, I don't think what we were saying was really any different. I mean, in a sense, then it's less new, but it's also less recent. I think we have a recency bias in politics, in the media, and it's much more fun to talk about, you know, kind of the behaviour of politicians and who said and what and who didn't and will she, won't she kind of stuff than these bigger issues.
Thank you. We've got 2 last questions, and may I ask, could we take those together? Because I promised those people with my eyes. So we have a gentleman at the back with the blue on, and we also have someone at the front with their jumper on their shoulders.
Thanks. I'm Chris Todd from the university. I'm a professor of primary care, community health, and I also lead the Healthy Ageing Policy Research Unit. Very nice talk. When we're trying to influence policymakers and the Department of Health, and we're presenting the evidence on what works, and I'm going to your table on what works with the countries and the interventions, we quite often like to also grade or classify the quality, certainty of the evidence. What would you say about the certainty, stroke quality of the evidence that underlies what you are saying about the different components of policy changes?
We just hold that. And one last quick question from the front, please. Thank you.
Thanks. David Denning. I'm a clinical academic with an interest in infectious diseases. So I just wanted to make 2 little points. I think related to cost effectiveness of interventions. So vaccination has been fantastic in terms of reducing childhood deaths and so on. In the health service, smoking cessation clinics are fantastically cost effective, as 2 examples. But on the other side, something like 20% of all of our healthcare budget in the NHS is spent in the last year of life. That last bit, when you go into ICU or cancer treatment and so on. And that's, I think, not sustainable in the long term. Do you have a solution for that? How would we approach that problem?
Thank you.
So two questions. One's about the quality of the sort of studies and the evidence underpinning, you know, what I talked about. And the second one is about what can we do about the fact that 20% of healthcare expenditure is on the last year of life. Right. Okay, the first one now looks a lot easier than it did when it was first asked. So obviously we've got all of the sources that we've used in, you know, cited in the book. Most of it's, you know, with the exception of like some work on Germany and an English study, then the most of it is like other people's work. so you can look at it and grade it yourself. Most of it's using natural policy experiment methods, so you can either like them or not, if you see what I mean, so kind of observational studies because it's public health. I think if you're into a kind of Cochrane hierarchy of evidence, you're probably not going to be convinced. But as I said, I'm not sure we'll ever get enough evidence if that's our kind of our approach to it, because we don't get randomization into being poor or not. We don't get randomization into living through a particular period or not. So, you know, it's not that I'm anti any of those things. I've done lots of systematic reviews, even been involved in a trial. I'm just not sure we can measure big macro things using them, that's all. But I'd be happy to discuss if you think we can. And then to the other one, which is, you know, like the fundamental challenge, isn't it, for us? Any kind of off-the-cuff remark would probably be a bit callous potentially and ill-considered, because it's not something that I look at. What I would be looking at is the inequality, you know, rather than what do we do about the kind of pressures of an aging population on a health system. I would argue that that's beyond my expertise, unfortunately. I know that looks like I'm getting out of it. But, you know, you can have kind of radical approaches in terms of who you ration care to. But I'm not sure of the public health ethics of that. And again, I wouldn't want to say something that's beyond my expertise on that one.
Thank you so much to Clare for that grilling on both sides and for the lovely, curious questions that you've had. I'm going to pass over now to Nikki just to close the event up for us all.
Thank you very much. And the only thing between you and your canapé there, I'm going to be really, really brief. First of all, a huge thank you to Clare. This is our third Health Inequalities Television annual lecture. I thought that was absolutely fantastic. And we could have talked all night, but I don't think that's fair on you. There are so many questions. I was particularly struck by your comment towards the end, which may have been slightly throwaway, because this waxing and waning, right, is annoying, isn't it? You just think, why can't we learn? And you did make a comment, which I don't want you to respond to now, but maybe later, where you said if we could get some of this stuff enshrined in Constitution, you know, we'd be in a better place. And, you know, if only we could do some of that. So I want to thank you hugely for coming to visit. It's been fab. I want to also thank Sarah, my new co-director, for it's so great to have somebody to get to do this sort of stuff and do the Q&A, which I historically have done, and I hate it. Despite what people might think about me, I absolutely hate the limelight. So I am really, really happy to share that now. So thanks, Sarah. Huge thanks to Laura and Louise, who have set this whole thing up and choreographed it brilliantly. You are fantastic. Just encourage you all to stay and chat, because that is also what this is all about, and that will be fabulous. And the other thing I want to encourage you to do is, if you can, pop downstairs and see the Hokusai and Hirashagi exhibition, because it is fantastic. As somebody who likes Tintin and Tintin cartoons, it's kind of reminiscent of that, and it's absolutely glorious. It's open till 9 o'clock, so do try and go and see some of that as well. So thanks, everybody, and enjoy a drink. Thank you.